All right, why don't we go ahead and get started? So welcome to the March edition of the Center for Behavioral Intervention Technologies Digital Mental Health webinar, which we're holding in collaboration with the Society for Digital Mental Health. I just want to let people know that we are recording this session. When we have the talk, please, as we're going through, put your questions into the Q&A, and we will get to those at the end of the talk. And today, I am really pleased to introduce to you Michael Schoenbaum, who is an economist with a PhD from the University of Michigan. He's the Senior Advisor for Mental Health Services, Epidemiology, and Economics at the National Institute of Mental Health, and he conducts research on mental health burdens, service use, costs, intervention opportunities, and other policy-related issues in support of NIMH's decision-making. So I'm really pleased to have you here today, Michael. Go ahead.
All right, thank you very much. I'm still not, I have to say, I'm still not used to speaking to an audience in this form by Zoom. So I am an economist and epidemiologist at the National Institute of Mental Health. Broadly, I have two mandates. I conduct research on mental health, health services, health policy, public health issues in support of institute decision-making. And I have a mandate. This is actually, the second part is the thing that really brought me to NIMH. I have a mandate from our leadership to represent our science to a really wide range of outside stakeholders in service of translating it into policy and practice so that it can have public health impact. That's very broad, and we can cover additional details that seems relevant. Some kind of housekeeping by way of disclaimers at the top. So first, I'm going to speak without slides. I apologize to those of you who think of yourselves as visual learners, but nothing I'm going to say here is visual. So I'd rather that this just be a conversation. Second, elephant in the room kind of thing. NIMH obviously funds research. Many of you, this mechanism even may be recipients of NIMH funding. I want to be clear, I represent the science, not the money. If you want to talk to NIMH about funding, please contact my colleague, Adam Haim, who I expect many of you already know. Third, my comments, and please take my word for this, the comments I'm going to provide today are my own and not necessarily those of my employer. Next, I don't have any conflicts to disclose that I'm aware of. One benefit, in my view, of working where I do is that literally the only dog I have in the fight is the public interest. I can and regularly do talk with commercial entities, including companies developing digital and I guess what one might think of as analog therapeutics or other discrete intellectual property, and also a wide range of other kind of organizations with commercial or proprietary, parochial interests. Mainly in healthcare, so payers, employers, electronic health record vendors, guilds, etc. Since it's obviously not my or NIMH's job to advantage any particular company over their competitors, our general terms of reference are that we will protect confidential information that people share with us, but the comments, advice, thoughts, whatever that we provide to others are open source, except to the extent that they embed confidential information belonging to whoever we're talking to. And the second kind of principle is that we will talk to, if we're talking to one entity in a space, at their request or our request or whatever, on principle, we will talk to any entity with similar standing if there is interest. Of course, if or when we run out of bandwidth to have conversations like that, then we'll need to update our terms of reference to be appropriate. But so far, I guess happily, I don't know. The reality of it is that so far, we have a lot of things going on, but it's not like industry is beating down our door to have detailed, substantive conversations about this kind of stuff. Okay, next. I do have a few outside affiliations. All of them are unpaid. I am an advisor to the Ames Center at the University of Washington, and I'm a board member of the Mental Health Association of Maryland, which, among other things, the Mental Health Association of Maryland owns Brain Futures, which is active in digital mental health. I don't directly participate in anything related to Brain Futures, but I just want to disclose this stuff to, err on the side of transparency. My last disclaimer, I really am not an expert on digital therapeutics. I haven't really worked directly on them. I haven't even really used them. I did, as a reality check, look at my phone, and it looks like I currently have 2 apps on my own phone that might qualify broadly under this umbrella. One is an app-ified version of the Columbia Suicide Severity Rating Scale, which I downloaded because the Department of Homeland Security has pushed that onto all of the agency's mobile devices across the whole scope of the Department of Homeland Security as part of an agency-wide suicide prevention initiative. And so we're interested. And the second is, I guess, to be candid, the Veterans Administration's app for coaching, self-coaching, whatever, using the tool. People in CBTI, the version of CBT meant for insomnia, which I will admit, it's one of my New Year's resolutions to try, but now it's March and I haven't gotten there yet. I guess that's how New Year's resolutions work. Also, I do not claim to be at all current about the science, let alone the practice of digital therapeutics for mental health. So I will acknowledge up front that I'm going to probably spend a lot of time in this session painting with a broad brush. I do invite pushback when there's a chance for that. My principal point of contact with digital therapeutics and the path that took me to getting invited here has been discussion efforts, whatever, about how to pay for them, and more specifically, how we might get health insurance to pay for them. What do I bring to this? So that's a good question. One answer is that I'm an economist working in mental health. There aren't all that many economists working in mental health. And people often conflate economics with money. So they assume naturally that, economists work on this. And I mean, I guess that's more or less true, but not strictly, maybe more to the point. I have in the past, and I mean, on an ongoing basis, worked with health insurers on coverage and payment for specific mental health services. And in particular, I've worked on essentially all aspects of translating the collaborative care model from research to payment, including the opportunity some years ago to work closely with CMS to implement Medicare payment for collaborative care. That process became what are now CPT codes 99492, 99493, and 99494. And after Medicare acted, then also we've been working with commercial payers and state Medicaid programs to add payment under those insurance mechanisms for collaborative care. That is ongoing work as it happens. In the last half hour, I got an email from colleagues that the Maryland State Senate unanimously passed a bill on the Senate side, currently under consideration in the Maryland legislature, to add Medicaid payment to Maryland Medicaid for the collaborative care codes. So it kind of my experience, I think everything that I have to offer in this conversation is sort of based on my experience thinking about pursuing and in some cases achieving payment for analog health services via insurance. In the rest of my prepared comments, I'm going to offer a kind of general framework for how I think about pursuing insurance payment for specific interventions. As I think will be clear, I think it's actually essential to discuss specific interventions in the concrete. Aside from some general principles, kind of what I'm going to provide, I think it's really not useful at all to imagine that some one-size-fits-all approach could work, or that we would even want to try it working to pay for digital therapeutics, centrally because the umbrella digital therapeutics, or digital therapeutics for mental health, or digital, whatever the vocabulary is that one uses for this, that umbrella spans. What that umbrella spans is incredibly heterogeneous. I'll talk some more about that. So I think the idea of at the extreme, a single billing code for digital therapeutic NOS is just a non-starter, and focusing in that direction. And I know that there are some people in the field who have, in the past at least, I mean, not that this is a totally stylized straw person. I mean, I have participated in conversations with serious professionals who have pursued and in some cases even proposed billing codes of the form digital therapeutic NOS. I really don't think that that's useful. So maybe after I comment about general principles, we could use whatever time is left to talk about some potential use cases, because this is an audience of people who are attached to use cases, if I understand correctly. So, as I mentioned at the top, the dog that I have in this fight is the public interest because of where I sit. Viable payment so what I care about, what I have a charge in some sense to think about, is viable payment for tools that are plausibly safe, effective, and efficient. To the extent that somebody's private interest differs from this public interest, I'm either neutral or I'm actually opposed. Put another way, absent credible evidence, and we can talk about what credible evidence might mean, but absent credible evidence, so the given product is clinically efficacious at minimum, I'm unconcerned if health plans don't pay for it. Indeed, I'm frankly glad if they don't. So, to framework. The way I think about this, for each specific product, digital therapeutic, whatever the term should be, I think what I would like to see is clear and credible information on who is the product meant to be used by, and how is it meant to be used? What are the clinical problems the product is designed to solve? What is the evidence that the product is actually efficacious or effective for those problems? What are the current alternatives or substitutes for using this product? And how does the performance of the digital therapeutic compared to those alternatives or substitutes. In some sense, kind of what's the kind of factual, think of it as comparative effectiveness. What's the value proposition, and or what are the cost drivers? So there, there's, again, it's hard to talk about pricing in the abstract, but broadly, at least I would think about, one can do value-based pricing or one can do cost-based pricing. For tools that are proprietary and unique in the sense of not having clear clinical substitutes, then value-based pricing may actually make sense from an economist perspective. Broadly, although the conversation about this is often kind of muddled, that's the basis that developers have used to set prices for new treatments you all may be aware of, because for various reasons, including that we read about them in the newspaper, treatments for hepatitis C, or for sickle cell anemia. This stuff that's come about in the last few years, and that has, in absolute terms, fantastically expensive price tags associated with such products. Very broadly, and I'm really not an expert in this, but very broadly, the way I would understand the basis for those fantastically expensive price tags, 6 figures, in some cases even 7 figures. The basis for that is that these products are curative for problems for which cure was not previously possible, and for which the human and economic value of cure actually compares favorably to the alternative treatment trajectory, right? Which is to say, expending for non-curative services plus the disability, suffering, shortened lifespan, and so on, that follow from treatment short of cure. So those are special cases, right? Where something is proprietary, unique, and high value. In the more general case, I think in healthcare, we mainly focus on covering pricing based on covering cost, or more to the point, cost plus, where the plus refers to profit in some form. If one is to pursue, if one is going to pursue value, you have to be able to demonstrate and denominate the value. If one is going to pursue costs, then whoever one is, payers need to understand somebody needs to understand the base of the cost drivers. So does the technology involve consumables? Does it involve some type of other variable cost? What is the basis of variation? Does it vary, by patient, by single use, by the device if there's hardware involved, by the installation, the clinic, the total number of patients or clinicians or sites, the time window over which it's used? There are all kinds of margins. Again, one has to talk about it in the concrete. Does the product require time and effort from any human professional versus time and effort from the patient or from patients' informal caregivers? If so, what time and effort? And does it require input for some other kind of technological input? So does the digital therapeutic need to be used in combination with other technology? Does the technology replace time and effort from any human professional, or replace some other product or service that would incur cost? So stepping back a bit, so those are kind of criteria that I guess I think that I would want to see on any product as part of a, working towards a conversation about payment. So the other dimension, and the kind of the second part of my prepared talks about this, is about payment mechanisms. So what mechanism might we use for payment? And broadly here, there are a number of different options. So the one that I have the most experience with is procedure codes. We have two systems for these in the United States, right? The CPT taxonomy system, which is run by the American Medical Association, and a system run by CMS, the Centers for Medicare and Medicaid Services, called HCPCS, HCPCS. Both of these have standard ways for interested parties, including outside of the respective organizational structures of CPT and HCPCS, third parties, to propose new codes. Both systems coding actually has two parts: defining the codes themselves and determining valuation. And the logistical details that I described above are actually relevant for both parts, because typically a code needs to specify what does the service consist of? Is there only one service element? Are there multiple service elements? If there are multiple service elements, those need to be spelled out. Which patients qualify for the service? In which care settings is the service meant to be used or furnished? If staff are involved, what types of staff qualify to furnish the service? Those things need to be specified in the terms of the code, because they define the circumstances in which the code can be billed. And those details collectively help determine the valuation of a code. I will say that creating a CPT or HCPCS code, and even creating a code that is assigned a non-zero valuation, is not a guarantee of insurance payment, but having some type of code may be a prerequisite for payment. Our health system, for better or worse, is designed. Coding is a kind of reification. From a health insurance perspective, if it has a code, it exists, and if it doesn't have a code, in a way, it doesn't exist. Okay. So procedure codes. The second category of things, which I know has been a focus for many developers of digital therapeutics, but is actually something I know a bit less about and have less direct experience with, are drug and device codes. Again, I know that a lot of focus among in digital therapeutics has been to get FDA certification. And my understanding is that FDA certification of digital therapeutics broadly has followed a path that is much more similar to FDA actions on devices than to what FDA requires for a new clinical indication for a drug. Now, while I know that some products in this space have been certified by FDA, my understanding also is that so far such certification has not provided a clear path to health insurance payment. And I think there are a couple of different reasons why that might be. One of them is that the standard of evidence for certification, to get an FDA certification under the current process, has evidently not convinced payers that a given product is actually efficacious, effective, let alone efficient. I mean, a clear example of a statement to that effect was issued a few years ago by Aetna. Many of you have probably seen. I mean, Aetna, where Aetna issued a public statement explaining, in short, why a number of enumerated digital products, in their view, lacked sufficient evidence of efficacy or effectiveness, such that Aetna was declining to pay for them. Those were not limited to mental health products. I think they spanned a range of domains of health, but they included some mental health products. Anyway, I will say conceptually and logistically, digital therapeutics often don't seem to me to be readily analogous to medical devices. Is it a thing you buy in discrete units, such as that if you give it to or use it with one patient, or in a single patient visit, then you need another one for the next patient or the next patient visit? That's inherently true for many devices, but it isn't necessarily true for digital therapeutics. If the analog here is a software license, then where the software license says you need to buy it by the use or something, pay for it by the use, then that's only analogous because of how the developer has chosen to implement the license. It's not intrinsic to the product itself in the way that it would be for a stent or a artificial joint or something. So here too, I mean, I guess as with CPT and HCPCS codes, FDA certification is so far also not sufficient to ensure insurance payment. I mean, I guess I would say it's also not necessary to ensure insurance payment. Some other options, and I'm getting to the end of my prepared comments. Yay. Insurers could license a given tool for their entire beneficiary population, who then self-refer or are referred by clinicians to that tool. The same approach could be used for digital tools that are meant for clinicians. The only caveat, I guess, I would add to individual payers making tools available to clinicians, if the unit of implementation is the clinician, is to note as a general matter that it's very difficult for clinicians to implement payer-specific workflows. So having one health plan pay for something that a clinician could then have available for some of their patients of a certain type, but not for all of their patients of a certain type. In practice, that's a huge transaction cost for payers to try to implement practice on a payer-specific basis. So for tools that clinicians use, clinicians could license a given tool for their entire practice. Whether this makes economic sense depends on the value proposition. But again, for things that aren't physically consumable, there are lots of ways to write license agreements. People sometimes, I've been focusing here on insurance payment. The conversation, of course, also includes products that are sold directly to consumers, where, I mean, I suppose the FDA analog is either metaphorically or perhaps literally a designation that the product be, over the counter. I think that's a way of saying the patient pays, but perhaps the designation would have the benefit that a patient could use pre-tax money to pay via a flexible spending account for healthcare. I mean, there are lots of products that are just sold directly to patients, lots of apps, right? Where the business model is direct to consumer marketing, and the patient pays, and so far, I think a lot of those things would fall outside of the regulatory scope of what could be reimbursed under a flexible spending account. To do that latter thing, you need some mechanism that gets activated. Anyway, I'm gonna actually finish at this point. But by coming back to where I started, I think it's essential to think about all of this in the concrete with respect to specific products and specific use cases, rather than in the abstract. And maybe some of you all, this black box of audience that I can't see, have some specific examples that we could talk through. but also from where I sit. I really want, and I think it's fair to say NIMH really wants to focus on products that have been shown to work. And in all candor, but with the caveat that my info about this may not be fully complete or current, I struggle to think of specific products with sufficient evidence of efficacy or effectiveness such that I'd be willing today to advocate for insurance payment, but I'd love to be wrong. So David, that's what I prepared. And I'm happy now to answer questions, field pushback, wherever it is that the audience might want to go with this. And if we don't use the whole hour, then we don't use the whole hour.
All right. Well, thanks so much, Michael. And so yes, this Zoom webinar platform is not the best for the kind of conversation that you have, but I will mediate that conversation. So, folks, if you have questions, comments, pushback, arguments, go ahead and put them in the chat, and I will go ahead and raise them with Michael as in the order that they're put in. So, the first in there, Brian Mustansky, has a possible use case to discuss the effective digital health interventions for prevention rather than the treatment of mental illness or disease with behavioral antecedents like HIV or obesity. So,
yes. So I think of that less as a concrete. I mean, it's a kind of use case, but it wasn't what I meant by use case because it's not a specific product. I do think that. I mean, that what I had meant by use case was like this tool to do, this tool named something that does this one thing for, et cetera. But I do think that, I mean, preventive services that are intended for primary prevention, are kind of a weird special case of things, actually. Because often I guess because of a kind of tragedy of the commons dynamic in the way we finance health insurance, right? That because in essence, what we're doing is asking, we're asking payers to pay for services where the payer pays now, and the benefit accrues to the patient or to future payers, a long way down the road. I guess I would say that's a special case. Many of the general principles that I mentioned before apply in this situation too, right? Like, what exactly is the empirical basis for asserting that the thing works as intended, that it actually does prevent the things, help prevent the things it intends to prevent. I'll mention one other thing by way of kind of free association that I think, we don't have a good answer for at the moment, which is the Americans, I mean, until the pending lawsuit about this, federal litigation is resolved at least, the ACA included a provision that was intended to put a kind of a federal regulatory thumb on the scale of making preventive services more widely available via the U.S. Preventive Services Task Force recommendation process, right? So specific services that the USPSTF has judged to have sufficient evidence that they work, warranting an A or B grade evidence grade by the USPSTF. Health insurers need to cover, and they need to cover a zero patient cost share. Now that begs the question of what's the mechanism by which the health plan pays. The problem with digital therapeutics is a different one, which is how is it determined that a digital therapeutic would fall within the scope of primary care? Because this USPSTF preventive services mechanism only works for primary care. The USPSTF scope is explicitly primary care. And so digital therapeutics that might be furnished directly to the patient, like there's an additional wrinkle that the deployment mechanism would need to be tied in some identifiable way to the delivery of primary care in order for it potentially to trigger that USPSTF review process. That's what occurs to me, about that. So.
Well, so Brian did have a follow-up, and then I'll go to the next question. He says, so the use case is the CDC has endorsed some behavioral intervention technologies as best evidence for HIV prevention, but the payment model for delivering them to people at high risk for HIV is totally unclear.
Okay.
Thoughts or
right.
directions for that?
So I don't know the specific I don't know these specific products. But I guess I'll offer an analogy where it occurs to me that the problem is maybe similar. So the USPSTF has issued a recommendation, a grade B recommendation for psychotherapeutic intervention to prevent postpartum depression. That's a thing. And in its recommendation, the USPSTF has named some specific intervention, modalities of psychotherapy. So, so intervention models with a designated name that link back to clinical trials that we funded in some cases, that are the basis for showing that the intervention is, is effective. So they have these named interventions. Now, the problem turns out to be that those named interventions don't map to any existing billing codes. In the form that those interventions were tested, the way they were delivered, how they were staffed, who they were staffed by, they don't fit under any current insurance payment mechanism, right? They don't fit under the psychotherapy billing codes as they currently exist. So this is a discrete evidence-based practice with bona fide RCTs and a USPSTF recommendation, on the basis of which, if insurers recognize these to be real services, right? If they've been reified for insurance purposes, then they would be available to patients with zero patient cost share because of the USPSTF recommendation. But because they don't map to any existing billing codes, they functionally just don't exist in the world, right? Like insurance doesn't recognize this to be a thing, and so there's no way for patients to get them. And I think that's essentially the scenario we're talking about, right? For these HIV things, like whatever those products are, because they don't map to any existing payment mechanism such that health plans recognize it to be a defined thing for their purposes, it falls into this limbo. So I guess what I would say about that is that's a specific case. You take those products and you go to, I don't know, maybe an FDA code would do it, or I would think more a CPT or a HCPCS code, and you go to those people and say, look, CDC recommends this as an indicated practice. It's a thing. Can we create a billing code, partly for purposes of payment, but most immediately for purposes of reification, right? It means that you've turned that product from a thing in the world into a thing health insurance knows what to do with.
All right. The next is really more of a comment. So Pearl McGee-Vincent is pointing out that your CBTI coach is not a digital therapeutic, and the VA has another one called the Insomnia Coach. But she also here has a tool from the Digital Medicine Society that I'll pop into the chat for people that can help you go through and determine whether the correct pathway for regulation in the United States. So I'll pop that in.
So can I say thank you? My guess is that other people, I mean, thank you on both counts, right? My guess is that other people will find this thing useful too. I will say, I mean, regulatory pathway, right? So the regulatory pathway is the thing that has led people to take products to, to get FDA certification, whether they're literally required to get FDA certification, I don't know. They're at least permitted or enabled to get FDA certification. What I would say is that the problem, again, with the FDA certification process as I currently understand it, is that it doesn't, unlike the requirements associated with getting a clinical indication for a drug, FDA certification for digital therapeutics, or more generally for devices, is not a sufficient basis for establishing that the thing is effective in the way that an insurance company might want to know that it is effective. So, it's a pathway, you can follow that pathway, but the clear evidence so far from experience is that getting that kind of certification is not enough, doesn't seem to be enough anyway, to persuade payers to pay. Given my understanding anyway of the meaning and the history of that FDA certification mechanism, I guess I'm kind of sympathetic to payers, honestly.
All right. The next question from Benjamin Aloof. Can you elaborate as to why you would advocate for payment? Would love to hear more about that. I'm not sure that you're advocating that, but
meaning so the emphasis here is not on payment. The emphasis is on you, as in, why would I advocate for payment?
Why would one?
One. Okay, so
I don't know.
Okay, so I will. So I don't. I mean, Benjamin, maybe you could clarify if my answer is non-responsive. Look, our objective, NIMH's objective, like it's in our mission statement in one form or another, right? I mean, it used to literally be our mission statement, but then it got revised, and the new wording is a little less clear. But the mission statement used to be, reduce the burden of mental illness in the United States via research, right? But the focus is basically reduce the burden of mental illness in society, right? So I guess what I would say is that, no, okay, so Benjamin, yes, so you're asking about me. So what I would say is, for my part, right, I feel like I have this great privilege to work under a public health mission from my leadership, and that public health mission is, broadly, I interpret it as where we have identified plausibly better treatments, better in the sense that using them on a population basis would reduce the burden of mental illness, in the United States. I feel like there is a public and not just a private stake in such interventions being used. Now, it is of course true when there's a commercial owner of that thing, the principal response, the principal incentive for pursuing widespread implementation lies with the IP owner, because they, that's the business model. But so maybe I should use maybe I should be careful about how the way I use the term advocacy. But I do feel like, again, where there is reasonable evidence that wider use of some new thing that is not currently in wide use would improve population health outcomes. I feel like it is within NIMH's lane. We have an interest in seeing that those such things become used on a population basis. Again, my comments are my own and don't necessarily reflect the views of my leadership, but that's how I understand the kind of public mandate.
All right. So the next question, the mental health parity would require health plans to cover preventive services for mental health as it would do so for physical health. If a digital application, if digital apps are available for preventing mental health, they would need to be covered under mental health parity. Sounds like it opens a bunch of questions here.
Well, yeah. So that, I mean, look, I'm all for parity. There's a form of interpreting parity. So I've asserted in this, up front, I've kind of planted a flag saying I'm really only interested in kind of focusing on the implementation in real world care of interventions that have plausibly been shown to work. I am endlessly reminded by my friend and colleague Henry Harbin that the modal healthcare service in US practice is supported by 0 RCTs. And strictly what parity says is that the terms of payment and coverage under health insurance can be no more restrictive for mental health services than they are for physical health services. And at the extreme, there's kind of an interpretation of parity that if insurers cover physical health interventions based on little or no evidence, then parity requires that they should cover mental health interventions based on little or no evidence. I can't bring myself to be enthusiastic about that interpretation because I don't think, honestly, we should be disseminating anything on a widespread basis without some reasonable evidence. But the final thing I'll say about this is, so the devil really is in the details, because that example that I provided before, where somebody in the chat mentioned those HIV prevention tools, and I mentioned that prenatal postpartum depression intervention, psychotherapy. I mean, again, that postpartum depression thing, that is not just a science-based preventive service, it's a preventive service based on science that in a way has been reified by the US Preventive Services Task Force, which gave it a B recommendation. And even so, it doesn't exist. And in real world health insurance practice. And the reason it doesn't is not because it's a mental health service, it's because it falls between the cracks of existing billing codes. And therefore, insurance companies don't know what to do with it. And therefore, it isn't available to anybody with or without patient cost sharing. So it gets us back to well, if you have some defined thing and that defined thing plausibly works, then there are some additional steps that are probably prerequisites for it becoming available in insurance, and having a billing code associated with it, or a NDC code, or whatever the FDA process yields, is probably on the critical path.
All right. The next question from Dr. Abdi Tinwala, can the issue regarding billing codes be addressed through state legislation? And maybe it might be good to talk a little bit about the role of legislation versus the agencies that manage these billing codes.
Right. So I guess a couple different things occurred to me. First of all, the one dimension of this, which I kind of mentioned already at the top, is there are things, having a billing code isn't in general a guarantee that insurance companies will cover the service and pay the code. There are lots of things that have billing codes that insurance companies exclude from coverage, or functionally what they do is they assign a zero valuation to the billing code, which is just to say, you can furnish it, whatever, you can do what you want, but we're not going to pay for it. Now, when there are state legislative actions that can help with that. I mean, I mentioned before the most obvious one is state Medicaid decisions, right? Because Medicare coverage and payment are determined more or less nationally. It's a little complicated, but more or less nationally. Medicaid coverage decisions are determined either by Congress or by each individual state Medicaid program. And so, and often state Medicaid program coverage and payment authority for that lies with or rests with whatever requires legislative action at the state level. So, state action may be relevant in that way. There are other ways that states can act. States also regulate some commercial health insurance, right? So if you're an ERISA covered plan, you're exempt from state legislation. You're covered under federal. You're regulated by the federal government, right? The kind of large employer self-insured health insurance. But for commercial health plans or exchange health plans or whatever that are regulated by states, the state legislative action can direct that such health plans must pay for specified services X, Y, and Z. And so under those circumstances, there is a process by which a state legislature could direct that the health plans regulated by that state must pay for a certain service. And then operationally, that would typically require that plans, if there isn't a CPT or a HCPCS code for that thing, then plans would, functionally they would end up creating their own code, or the state would create a state-specific code or something. I don't really understand how that works in practice, but I mean, mechanically, insurance payment invariably involves a code of some form, and it may be that what health plans end up doing to operationalize a requirement like that is just to create a plan-specific code, for whatever the service is. All right.
So from Lindsay Engelman, what's the difference in evidentiary requirements for Medicare and Medicaid? Medicaid only reviews existing authority in statute 1905, the Social Security Act. What about Medicare?
All right. So I don't know how to speak authoritatively to this. The way I understand it broadly, Medicare. So first of all, so Medicare there is a standard process for Medicare to determine whether some new thing is or should be covered by Medicare. I mean, one question is whether some new thing falls within the statutory scope of Medicare service, which I guess is a legal question that lawyers determine. If the answer is it falls outside the statutory scope of Medicare, then it can only be added by congressional action. So as an example, kind of adjacent to anything we've been talking about here, until a couple of years ago, Medicare was statutorily unable to pay for methadone treatment for opiate use disorder in opioid treatment programs. And that's because methadone care for OUD can only be provided in these designated things, opioid treatment programs that are regulated by the DEA. And the Medicare statute didn't permit OTPs as a place of service that Medicare could pay for. And so it didn't matter what the evidence was on methadone treatment for OUD. It could only be, as long as it could only be provided in OTPs, and Medicare couldn't. And OTPs weren't a statutorily approved place of service for Medicare. Medicare couldn't pay for those services. And a couple of years ago, Congress acted to fix that so they could pay for care in OTPs. So right? So that required congressional action. For things that are in the statutory scope of Medicare, there's this thing called the Medicare Evidence Development and Coverage Advisory Committee, MedCAC. And so one applies to the MedCAC for a determination about, new things that should be covered by Medicare. That's a standard process with SOPs. And then there's a third kind of path for Medicare, which is for things that are already covered by Medicare. CMS may determine that current payment mechanisms need to be improved or fixed or aligned or something like this. And so then the additional mechanism is typically some combination of creating billing codes and otherwise introducing rules for payment via the Medicare physician fee schedule. So that was the way the collaborative care services were added to Medicare. It wasn't a coverage determination. Medicare viewed those services already to be covered. The problem was that existing billing mechanisms didn't pay for them properly, and so Medicare acted via the physician fee schedule to create billing codes and to fund those billing codes under a payment rule. Medicaid, my understanding is there is nothing like the MedCAC, I think, for Medicaid. Medicaid does not make national coverage decisions. Again, as I understand it, and Lindsay, I'm sorry, this is over my head, the details of it. My understanding is that new things get added to Medicaid either by congressional action or state by state.
All right. We are almost at the top of the hour. So, and I think that kind of concludes it. I guess I have, one other question, I guess, that I've been wondering about is, so FDA regulates software as a medical device, but, it sounds like you aren't convinced that FDA is necessarily, that the role is not all that clear, and I think that there's a lot of confusion or debate about whether FDA should be involved. And I mean, what are your thoughts about, the seat of regulation and how that should occur in the United States?
So, I guess so. I don't really understand. I don't understand the extent to which a product is obligated to be certified. A software product is obligated to be certified by FDA versus whether it has the opportunity to apply for certification from FDA, but such certification is optional. My understanding is that it's more the latter than the former, that most of these digital tools are not obligated to be certified by FDA, but they have the option to do it. I generally think that the FDA's, the FDA has done the best they could, I think, with a very difficult situation, because, as I've asserted, and we're going to run out of time to talk about this effectively, I think that this space of digital therapeutics is an imperfect analog to anything FDA has regulated previously. It's not a drug, it's not a device. Neither, they're not applying the drug process, but they've adapted the device process. But I think that adaptation is imperfect because the analog is imperfect, because I don't think these things are devices in the sense of what the device process was intended to regulate. And so, for better or worse, what they've created is a square hole process for a bunch of round pegs. I think addressing that, it doesn't involve throwing rocks at FDA. I think they've done the best they can. Yeah. I think it's actually stepping back as a field and figuring out, articulating a new framework that is made to suit the current purpose. And again, I feel fairly strongly that starts at least with a taxonomy. Under this large umbrella of digital therapeutics, we need a taxonomy for product categories. because it's so incredibly heterogeneous. Products that are meant to support clinician decision-making and are never meant to be used by a patient are in the same bucket as products that are meant to be used directly by consumers and never have any involvement with a clinician in any form. But they're apples and oranges. So, I mean, I guess I'm throwing it back to the field, right? It's like we need, as a field, a coherent framework for how we would propose to navigate all of these things, and I don't think we're there yet.
Yeah. All right, Michael. Well, thank you so much. This was this was great. And we try to have the perspectives of lots of different people from different walks of life and different professions. And so I appreciate your taking the time out to talk with us today.
Right. Well,
and so
it wasn't a total waste of time.
No, it was really interesting. And so, folks, the video will be posted in the next few days on the CBITs site. And next month, Joe Glass and Teresa Matson will be talking about a framework for trial design that's being used by Kaiser Permanente. So thank you very much, and we will see you all next month.
Thank you.
Thanks a lot.